Sir is from Hamad Medical Center, top researcher, and happy to be here, sir, together in the morning session. And so we also welcome all the participants who has come in time for this morning session. And let me take the honor of inviting Dr. Prabhat. And Dr. Prabhat is an eminent speaker. He is a specialist in acute internal medicine and a principal investigator focusing on sepsis and efficiency in acute care. He serves as a full professor at Amsterdam University of Medicine, affiliated to the research program in diabetes and metabolism, digital health, and quality of care, Amsterdam. So beyond his medical career, he is also a great singer as well as songwriter. That's a great one, Dr. Prabhat. I didn't know about it. And he really exemplified the power of synergy between science and art. So this is the introduction for Dr. Prabhat. I'd love to hear your thoughts, sir. Over to you, Dr. Prabhat.
Hey, thanks. Thank you. But the hall is full, actually. You're making lots of noise. Very good. Also, for the people who are here, I just want to talk about the noble art of leaving out. What do I mean by that? In the last 15 years, we have done research on this theme. So one of the things we said is, you got to do everything possible for the patient. You got to do as much as possible for the patient, and you got to do as little as possible to the patient. So we teach our students to do something when they come to the ED. Always do something. And what we have trying to teach our students is, try to do everything you think is necessary, but things which are unnecessary. So I'll be talking about a nationwide project we did in Holland called Rodeo Project, which we started a long time ago. Why did we start the project? We know that about 30% of the tests we do are redundant in retrospect. So what we said was, these are all research which is done by, this is international, this meta-analysis. This was a research done by our department also, where you have seen that CT scans double every 10 years in the last 40 years. We have been doing more and more and more CT scans. So this is a review written by one of my PhDs long time ago called Renuka Bindraban, where we looked at interventions which led to reduction of unnecessary diagnostics. And what we find out was, if you use these interventions, such as education, just talking to people, processes, talking about frequency of doing a test, clinical chemistry, implementing role models, local champions who people respect, to talk about tests. So when you do a test, why do you do it? What are you going to do with the results? Does it change your decision making? And also we looked at order systems, because we're champions in order sets, especially at the ED. When a patient comes in, you do a palette of tests, and then nobody knows what you do with the results. And also awareness and feedback, what you call mirror feedbacks. So what we want to do was, we want to talk to physicians, change their attitude about what they do, change thinking, and change behavior. We started a large project long time ago in our university hospital, where we just talked to people in these years. We just went to their departments, we just went to their clinical discussions. We talked about the things what they do that led to 13% reduction in diagnostics just by talking and showing them what they did and asking them. Now, one question was BUN, urea, was done 20,000 times a year. I could not see any one reason why you should do it. Sodium, potassium, 30,000 times a year in our hospital. Those are very cheap tests, but cost a lot of money. But not only that, you create anemia even in patients, even doing bad tests. So what we did was that we published this. This is one of my old PhDs called Iron Affecting. We published this in 2012. And then just went on doing that. And what happened here was we did it in the internal medicine department, and every department in the university took over, university hospital took over, and they started talking about what's the value of things, what we do. And what happened was our expenditure on lab tests went down, and when we stopped the intervention somewhere in 2013, it stayed there also, which means that our lab has to reorganize. Our radiology has to reorganize because people were asking less and less tests without compromising the clinical outcomes. Now, this is in Dutch. This is called a national project called Rodeo because the interventions went national. We were given a large grant to do a project called Rodeo. This is a mouse pad which we developed for this project. Multifaceted intervention with ordering of unnecessary robotics among caregivers in internal medicine. We did it in 4 large hospitals in the Netherlands. In this mouse mat, we had 3 questions. Does the results of this test have any consequences for the patient? Do you need to repeat the test now, or can you wait? Sometimes we do combinations of tests, SGOP, SGPT, creatinine, ureum, sodium, potassium. Is it necessary to do both tests, or you can just do one? So this is what we asked the doctors. And we took 4 hospitals and did a pre-intervention phase where I looked at all what they did in the last 10 years, and then show it to them and talk to the doctors, talk to the clinical chemists, talk to the young fellows, and then started the intervention during 6 months. We went to the hospitals, we went to their morning handovers, we went to their clinical discussion sessions, and just kept asking questions. Why do you do this CT scan? Why do you do this X-ray? We concentrated on cheap tests which were done frequently, rather than very expensive tests which was done once in a while and everybody was worried about. We also considered then those tests, and then we just measured post-intervention. This was in 4 hospitals in the Netherlands. And also we used young doctors who gave lessons during the morning handover. This is about blood cultures. Why should you do a blood culture? I'll come back to it later if I have time. So all this was done. And we published our results in JAMA in 2019. What happened was, in the hospitals which we were doing this intervention, all the tests reduced significantly. In some hospitals, even 15%. And we were measuring the mortality, the hospital length of stay, readmissions, admissions from the ED. Nothing changed, but only the test volume changed. And we had a reference group of 19 hospitals in the Netherlands. There was an increase in the test volume. So what you see was in the 4 large hospitals which we did, we reduced it by 11%, and reference group increased by 2%. And these rodeo principles are being introduced all over Netherlands now. Lots of hospitals, we have done a blueprint of what we did. It was not rocket science, just talking to people and showing them what to do and asking them. So I think we presented this also to Saudi Arabia in one of their sessions, which was a pretty interesting session where lots of people were interested in doing this. So it's choosing wisely with a different name, but with clear results. I have a little bit of time more. So I'm going to show you also, one of my PhDs won a prize last week on this. This is also about antibiotic and administration. So what we did, because of surviving sepsis campaign, is as soon as a patient comes, if there was a systemic infection, if there was a suspected sepsis, we gave antibiotics. And what we find out now is about 30% of the patients who we treat at the ED with antibiotics, in retrospect, don't need it. And that one of the reasons for antibiotic resistance is this. So what we did was we thought, we are going to randomize, because we could not randomize patients for antibiotics and placebo. I'm not saying that septic shock patients should not get antibiotics, but the patients who comes in, especially elderly, with aspecific symptoms, should you also give antibiotics as soon as possible. So what we did was we randomized in the ambulances. We gave the half antibiotics, other half got antibiotics in the ED, and we created a gap of about 1.5 hours in patients with sepsis according to SIRS criteria. There was no difference of the mortality. Of course, if you have sepsis, there was a trend. Of course, if you are very young, there was a trend towards betterment. There was no difference. So this is why, I'm going to show you this. This is, we showed our, we published this in Lancet, and about 2 weeks later, in Gray's Anatomy, they were talking about our study. I thought I'll share it with you if you know what that is. Now, I don't have the sound, sorry. So I'm going further. What have we done now? I got a couple of more minutes. What we went thereafter was, so we reduced the diagnostic by about 13%, and we said we are going to concentrate on one diagnostic, which was blood cultures. One of our PhDs, Rishi Nanan Pandey, did a project about the blood culture results. What we found out was about 85% of our blood cultures turn up negative. 15% turn up positive, out of which 50% is contaminated. And from the 7% or 8% which is positive, the results come about 3 days later. It doesn't contribute to clinical decision making. So what we are doing now is a study. And clinical decision, and the other one is lots of these blood cultures who turn out positive contaminated blood cultures cause harm to patients. They stay longer time in the hospital, they need longer treatment, they have increased diagnostic and even higher rates of complications. And there's also bottle shortage of blood cultures, and there's lots of environmental impact in all what we do. So what we're doing now is getting artificial intelligence algorithms at the ED, trying to see whether we could reduce as first the blood cultures. Unfortunately, because there's no sound, I can't show you this film. I will show you what we did. What we did was we developed an algorithm using large data sets from 4 hospitals in the Netherlands. Amber Den Holland is also here, who's heavily involved with the study. Validated it in our hospital, validated it in 4 other hospitals. I'm going faster now because of the time. 4 other hospitals. And also validated it prospectively, this algorithm at the ED. What does the algorithm do? It predicts the chance of positivity of blood culture. And what we ask the doctors to do is, if the chance is less than 5%, which is pretty conservative estimates, don't do the blood culture. And what we have shown is, if you don't do that, we'll probably miss 4 positive blood cultures, which turn out to be irrelevant in these cases, retrospectively, but you prevent about 30% of the blood cultures. And we have done it now in about 11,000 patients prospectively, and its algorithm is not losing its value. So what we are doing now is we are doing a large study in the Netherlands called ABC trial. Everybody who gets a blood culture gets a pop-up. The doctor gets a pop-up about the study with the exclusion criteria. We ask the doctor, do you think this is suitable to enter the study? Without these exclusion criteria, the EPIC randomized the patient. There's a control group. The doctor can do whatever they want. There's an intervention group. The algorithm is run. Less than 5% chance. We ask them not to do the blood culture. And this is running at the moment, and this is the way we have integrated that in EPIC. And so we are continuing it. Because of the time, I'm going to go faster. These are all publications on this trial only, so if you want to read it, you can read it. So what we say is, about 20% of the laboratory tests, 20% is in retrospect redundant. You can reduce it pretty easily if you think about it. So teach your students not to do things which is not necessary, not always do things. This multi-step producer intervention is successful and be implemented all over the Netherlands at the moment. And we are using algorithms now to reduce tests, and we will be implementing these algorithms on other themes. Some of our PhD students will be talking about it. Amber Den Holden talked about it yesterday. I think Nuka is going to talk about it also. So what you need is patience, persistence, and perseverance, and then you can get this done. Thank you.
Thank you, Dr. Abbas, for this interesting presentation. Any questions? May I ask a question for you? Yes. Which pre-hospital antibiotic you recommend for this without affecting the culture? Which type of antibiotic in the pre-hospital setting you recommend that will not affect the positivity of the blood culture in hospital?
Yeah, that's a difficult question because we use mostly ceftriaxone, cephalosporins, but depends on the antibiotic resistance pattern. And in the Netherlands, almost every patient who comes to the ED has been seen by a GP before. You understand? So you can use at the moment penicillins even in the Netherlands. You have heard that last week they presented data on floxapen, flucloxacillin, which is going out of practice also. We use ceftriaxone, but I think it's not. I think pre-hospital antibiotics, you can go much less extensive antibiotics therapy in the pre-hospital. Maybe still penicillin.
Okay. Just one question from my side. Dr. Pravan, is what was the definition of sepsis you took for enrolling the patient for antibiotic in the ambulance?
Yeah, we use an old definition, sepsis, there's with the SIRS, but even if you use Q-SOFA, our results do not change. So what we say is, take time to think, except if the patient is very sick. If a patient has a NEWS of more than 5, if the patient has Q-SOFA more than 2, yes, of course, then you have to strongly think about giving antibiotics. Otherwise, first think, especially in patients, we have also done studies to see whether in elderly giving antibiotics as soon as possible helps. It doesn't look like. So think, you got to give antibiotics, but first think and do the diagnostics.
Okay. Thank you, Dr. Prabhat.
Oh, there's one.
Yes, please.
My feeling is that we are doing less cultures even as soon as you introduce the AI algorithm.
Check.
So what you do with all this is also changing, making people think. So when they know that there's a trial going on, there's a Hawthorne effect, people know there's a trial going on, they think twice before doing it. So when you put a clinical decision algorithms, you will see that the practice change automatically also. So your question, has it changed? Already, yes, but the impact of implementing algorithm we have to test.
Particular scenario.
Yeah, there's no, Amber, there's no prediction different between elderly and young patients. But elderly patients, when you go to the diagnosis of infections soon, you miss other things. So because they come with an atypical presentation. So we have to just use algorithms to make people think.
Thank you, sir.
Next.
Okay, thank you. We'll go for the next speaker, Professor Vimal. Professor Vimal will talk about the blood management in the emergency department. Yes, he is affiliated with a lot of activities in the Department of Education, Emergency Medicine, Clinical Skills, Medical Simulation, and Resuscitation. So please, Professor Vimal.
Thank you to the chair for the introduction. Thank you to the organizing team and the leadership at Turkey, EPAT. I'll be talking on patient blood management in the emergency department. The session for free paper was done yesterday. This is on a newer topic which is gaining relevance in the emergency and the acute care settings. I am from India. I work in Kasturba Medical College, Manipal, an Ivy League university in the country. I've got no disclosures for this talk. And I'll start off with a case scenario. Got a young male, to the emergency physicians of the room. Car crashed onto a wall. He's in a belligerent state, no obvious external bleed. He's got a swollen thigh on one side. He's got shock. The triage nurse comes and tells you that the patient is crashing. What will you do next? I think we had a very good session on the updates in the trauma life support guidelines that have come in, and it's been rolled out in 90 plus countries right now. They tell you to go the X, A, B, C, D way. You look at X sanguinating hemorrhage, you look at airway, you look at breathing, you look at circulation, you look at disability, and you look at exposure and environment control. So what's different with patient blood management? It's a newer concept that's come in. We'll try to define the problem. We'll try to talk about what is patient blood management and hemorrhagic shock in trauma, what implication it has. We'll talk about the treatment strategies and the endpoints of hemorrhagic shock management. Now, defining the problem, shock has always been guided by numbers. And we always tell our residents, do not relegate medicine to numbers. Insufficient perfusion to the tissues, you use whichever numbers you want, you use whichever surrogate biomarkers you want, whether it's lactate or any other for that matter. You define shock in your own unique ways. The challenge with trauma, it's a beast, one of the leading causes of mortality world over, and it approaches 40% when you have a patient with hemorrhagic shock, and if not appropriately treated, the numbers might go sky high even from 40. There's a need for a rapid evaluation, identification, and management. It's time sensitive. Now, the problem with hemorrhagic shock is not the shock component itself like the other three domains of shock that we know of, whether it's obstructive, distributive, or cardiogenic. The challenge is with trauma-induced coagulopathy. Now, when you look at trauma-induced coagulopathy, shock in trauma following hemorrhage can lead to factor consumption, lysis, can lead to acute coagulation of traumatic shock. Acidemia and hypothermia are the other physiological parameters that can be a challenge. You look at hemorrhage leading to resuscitation, us pushing a lot of crystalloids into the body, can itself lead to dilutional coagulopathy, could lead to hypothermia with the non-warm fluids that we give, or the environment that the patient's coming from. Trauma in itself can kickstart a cascade of inflammation in the body, not to mention the medications that patients are on, the genetic component that the patient has. Now, patient blood management, it tells us to move away from the component administration. We're all bothered about how much blood component we're going to give, whether it's pack A, pack B, pack C. What does pack A have? Does it have plaque cells? Does it have plasma? Does it have cryo? How are you going to give blood, and what ratio are you going to give blood? The focus is on the product and not on the patient. Now, the Society for Advancement of Blood Management has given this newer definition, which claims that patient blood management is a patient-centered, systematic, evidence-based approach, and it's used to improve patient outcome by managing and preserving the patient's own blood. Again, it resonates with what ATLS wants you to do, and how ATLS has changed with the exsanguinating hemorrhage coming before the airway currently. Civilian trauma, although doesn't have a lot of impact compared to the tactical medicine or war-related trauma with regards to preserving the patient's own blood while promoting patient safety and empowerment. So it's timely, it's disciplinary, it is cost-effective and life-saving. There are numbers which can prove that preserving the patient's own blood or efforts to preserve hemorrhagic loss from the patient would in turn save a lot of money, not just for the patient, but for the system. The three tenets on which patient blood management is built is to treat pre-op anemia, detect and treat pre-op anemia, which is beyond the scope of acute care and injury sciences that we practice in the emergency department. The other two components, whether it's reducing blood loss or whether it's optimizing patient reserve, has got a lot of implication for us. We'll discuss how. The first component is damage control. We know we in the emergency setting or acute care settings, we depend a lot on damage control, which is a two-pronged strategy. The focus has been on ratio-based blood products with definitive care and hemostasis, whether it's going to the OR and getting an explorative laparotomy done, or the IR and the interventional radiology team coming and angioembolizing the vessel, which is leading to pertinent bleed. So the tenets are, again, preserving the physiological reserve and focus on hemostasis. If you look deeper, dive deeper into damage control, it's got 4 phases. So the phases of damage control resuscitation are DC0, which is pre-hospital, DC1, which is the initial surgical intervention if required, damage control 2, which is a resuscitation which is ongoing, and damage control 3, which is definitive repair. There is a newer damage control 4 component, which is on delayed soft tissue recon, which has also been added to the damage control entity or the domain during the phases of resuscitation, early phases of resuscitation to late phase of resuscitation. Now, if you focus our attention on the emergency and acute care setting, we're going to look into DC0 or damage control 0, phase 1, phase 2, and phase 3. In the pre-surgical phase or phase 0, we've had discussions from day before yesterday where Professor or Dr. Althani had discussed about pre-hospital phase and how staying there and playing for a longer period of time in Qatar had shown poorer outcomes. Spending more time on the field had led to poorer outcomes in that system, and getting the patient quickly to the hospital and not staying and playing led to better outcomes. So again, if you look at literature, the scoop and run versus the stay and play has got a lot of grayness in the way the conclusions have been drawn. Some systems still do validate the scoop and run more than the stay and play. It also depends on the resources which are available for the pre-hospital emergency medicine team, for the paramedic team, whether it's blood products, whether it is drug administration, whether it is airway management on the field, that they would be trained for. Expediting transfer to definitive care is a definitive plus point. Wherever you are in the world, the quicker you resuscitate, the quicker you transport, the better it is for the patient. Proven beyond doubt. The confounders are rural versus urban settings, settings where you have amazing trauma care services like the Hamad story that we heard day before yesterday in the plenary, or in developed systems in the West where they have a very definitive paramedic team which could initiate resuscitation, the damage control phase 0. If you look at the hospital phase, which is the phase 1, where you could have an acute care surgery or you could have controlled resuscitation. They would assess the physiological derangement and initiate treatment. There's been a lot of focus away from the anatomy towards the physiology in the resuscitation of patients, be it in the airway, be it in circulation, be it on ventilation parameters, or even intra-hospital transport for that matter. A lot of checklists are taking into consideration the components of the physiological tenets which can derange early. Now, if you look at the evolving standard care pathway of initial assessment and management, it's going towards preventive and also preservative component of resuscitation rather than just going blindfold as a cowboy to resuscitate. We all learned massive transfusion protocols. We've all been binded by protocols which are dependent on packets or written down documents on how much blood product, in what sequence, in what ratio that we need to give. There is a lot of focus which was on the component administration part, but massive hemorrhage protocol is a future where there is a systematic and coordinated delivery of care to bleeding patients. So there is a mindset that needs to be changed from the product towards the patient. So all massive transfusion protocols in the hospital in the coming decade would slowly cocoon into or metamorphose into a massive hemorrhage protocol. What are the benefits? You look at decreased variability in treatment, keeping the patient at the center of it. You look at reduced product wastage. There are instances where blood products, you would completely exhaust all your resources in the blood bank with a single person resuscitation, which is dependent on transfusion protocols and not on patient-related data sets. You look at improved interprofessional communication, we'll talk about that in a bit. Standardized process evaluation, and most importantly, faster time to transfusion. There is enough literature which is telling us that that is the way to move forward. Now, I'm a big movie buff. I believe that, a lot of old Western movies teach us a lot about medicine too. We'll talk about how the Magnificent Seven can help us redefine the way in which we manage trauma patients, specifically with hemorrhagic shock in our setting. What are the 70s, 60s? 70s, we'll take one out. You need to trigger the protocol. You need to have team prep and performance, which is one of my areas of interest, where a lot of our research is focused on team prep and performance. We'll talk about tranexamic acid, which again, post the CRASH-2 trial has taken the world by storm. It's a must-have drug in the ED resus bay. We talk about testing. Now, early testing is what they have defined, but we'll talk about testing in a different manner. We'll talk about transfusion targets. We'll talk about temperature management, and more importantly, we'll talk about how to terminate the protocol. Whenever we in the emergency department, we start off by telling, we need to initiate massive hemorrhage protocol in the department, or let's say the older terminology, a massive transfusion protocol in the department. We never think about when to terminate. It's important to start and communicate when to stop. So how do you do that? So like I said, we won't talk a little bit about tranexamic acid because it's been extensively discussed earlier. Our focus would be on looking at the other 60s triggers. How do you trigger? I think there are multiple ways of triggering transfusion protocols. Your institute would have its own ways of triggering a massive hemorrhage protocol. There's a lot of objectivity. A delay of 1 minute is associated with 5% increase in odds of death, so we need to trigger early. There are multiple scoring systems that are used, and most civilian trauma, you'd require 2 units of packed cell initially, and the patient would stabilize if you have excellent systems and excellent surgeons who can take up for explorative laparotomy or definitive care quite early. So a 2-tiered approach would be the best one for hemorrhage protocol management. Pre-hospital emergency medicine has to develop to also reduce the event of not calling out or not triggering transfusion early. Most importantly, think of the elderly population, think of the pediatric population, think of the pregnant female who is coming in with trauma, and confounding drugs, because longevity comes in with a balance of using a lot of drugs which can take coagulation out of the window. Normal coagulation pathways out of the window. So triggers, I'm just borrowing the table of the Petrosoniak article, where they say ABC score is good, shock index is good, but if you look at the sensitivity and the specificity per se, the RABT score, which is a revised assessment of bleeding and transfusion score of more than 2 predicting massive transfusion, has got a 78% sensitivity with a very high specificity, 91%. And a lot of people are moving towards the RABT score, RABT score, for initiating blood transfusion. It's slowly creeping into pathways. When we were doing our residency, a lot of people used the ABC. We're moving towards RABT now. Team prep. I think this is one big domain which requires a lot of focus today. In team prep and performance, there's a lot of focus on technical skills, and I know all the experts in the room have been teaching resuscitation for decades and knows the importance of resuscitation for decades. There is a need for talking more about situational awareness. There is a need for talking more about communication skills amongst team members in chaotic environment. There's a lot of need for talking about critical treatment decision making, task management understanding, and leadership skills. So if you look at teamwork, it's got a combination of a lot of non-technical skills and technical skills, and I feel now is the time to focus on the non-technical skills part of leadership, situational awareness, and communication at this point in time. Language is always a problem. The way in which we communicate during a code is always a problem. The way in which you communicate with other departments where you need blood and ensure that blood is in the system and patients taken to the OR for an X-lab is also important. The stack debrief is one thing which is very evident in literature, whether it is systolic BP temperature, acidosis, coagulopathy, and the surgical kit plan, or a situation rep, which is a communication rhythm you need. What we maintain is an hourly communication rhythm, where an hourly word is put out on the amount of blood that is taken in, the testing that is sent out, and the and the challenges that, or the changes that we've made after the testing. So the right decision for the right patient at the right time and the right place is what we need to focus on. Testing, we do viscoelastic hemostatic assays. And I think the future depends on good trauma centers depending on TEG or ROTEM for managing the trauma patients, because you can't just depend on pack A, pack 1, give off 4 packed cells and wait for your plasma, or wait for your cryo, or wait for other blood products which are required. Pre-specified institutional protocol acquisition sequences are going for a toss. We test for a 4-hour bundle. You could consider 2-hour bundles based on your resources. Targeted transfusion. There's a faster time to transfusion the moment you start viscoelastic hemostatic assays. There is a lot of focus on ratio-based transfusion, 1:1:1 versus 1:1:2. I believe the future would move more towards periodic testing massive hemorrhage protocols from ratio-based transfusion, packed cell concentrates in the absence of plasma, definitively viscoelastic hemostatic assays, and factor concentrate-based treatment according to the need. A quick word on fibrinogen, because a lot of women, a lot of pregnant females coming our way, we need to refocus the transfusion protocol. It can't be a one-size-fits-all strategy. The pregnant female who's coming in with traumatic hemorrhagic shock would be pushed into coagulopathy very, very quickly. Ensure that you transfuse fibrinogen early and maintain higher levels of fibrinogen, because that loss could be the slipping point for trauma-induced coagulopathy. Temperature control. Even American Heart Association has moved away from calling it targeted temperature monitoring. If you look at the 2013-2023 guideline update, which came at the end of 2023, early 2024, they're talking about calling this, renaming it as temperature control. So temperature management, I'm keeping it very broad here. Prevent hypothermia, regular monitoring. Evidence, what does it say? 1 degree increase in temperature, and in a hypothermic patient, you would reduce your transfusion need by 10%, which is very huge. You're saving money. You're saving resources in your hospital. So passive and active cooling and active internal rewarming if required. Terminating, this is very important. You need to have a written down protocol on how we're going to terminate transfusion. It's imperative that people do understand who is calling out the code, who is terminating the code, and they do an audit for the same as they move forward. Ensure that the whole team is in the loop, because sometimes the patient might be taken to the OR, operating room. The surgeon or the anesthetist might call off the transfusion. Ensure that the whole team, the transfusion medicine team, the acute care team, the intensive care team, are all kept in the loop when you are terminating the code. A small shout out for permissive hypotension. I know that all the members in the room are practicing permissive hypertension, except for instances when you have traumatic brain injury or a traumatic spine injury. Ensure that you have a passive process of permissive hypertension until you achieve hemostasis. Giving a lot of fluids might not help. Giving a lot of crystalloids might lead to a lot of trouble. Ensure that you reduce the amount of crystalloid usage. Ensure that you go into blood very quickly. And just to quote the 2016 NICE guidelines, recommend that you can have a carotid or a femoral pulse with a systolic BP of 80 to 85. You can go even lower, but remember the window for acute traumatic brain injury and spine injury. What are the other adjuncts? Just a couple I would name out here. Clamping the aorta with ED thoracotomy, the clamshell thoracotomy, the RIBOA, and interventional radiology. Getting interventional radiology suits with hybrid OT could be the game-changing step in trauma centers. Quick word on resequencing resuscitation. This was out in 2018. We've been talking about this maybe 10 years back. It's imperative that you consider massive hemorrhage control early. Don't just go by blind A, B, C, D. Don't be dogmatic with A, B, C, D, and E. Ensure that you control massive hemorrhage, preserve blood loss before you move on to airway breathing. And ensure that you cut down the dose of the induction agent and increase the dose of the paralytic agent in those patients who are very sick. Another pearl for the acute care clinicians in the room. I think everybody needs to have their own RIBOA algorithm. We are a country which is just stepping into the game with RIBOA now. The Baltimore shock algorithm is one good algorithm which has been published earlier, which has spoken extensively about what they do, how they go about, and which zone they place. If the patient's fast positive, it goes where. If it's fast negative, it goes where. And if it's got a aortic injury, you don't place it at all. So it's got its own well-delineated protocol. Moving forward, what do we need? We need QI initiatives. I think all the countries in the world are focusing on quality improvement initiatives on emergency blood management, patient care management, and damage control resuscitation. We need multidisciplinary teams with in-situ simulation exercises happening very commonly. We need a robust hospital emergency medicine care system and retrieval medicine system. And we need to look into the economic impact. I think money would speak louder than anything else. The moment we as clinicians sit down and talk about not just a patient, but also the economic impact of patient blood management, I think everybody would sit up and take notice. The way in which we manage this patient, this young kid, long back, I think initially we were very dogmatic. Nowadays we are very pro-patient, focusing on the patient, and we know what PBM is and how it can impact patient care. So don't be blind with resuscitation. Use your viscoelastic hemostatic assays. Ensure that you become the change that you envisage for the world. Quick shout out to everyone on WASN 2025. We'll be having it in India, 29th of October to the 2nd of November. I'd have everyone, welcome everyone. We'd have a skill school by the exemplary Qatar team on ED thoracotomy and Riboa. We have 12 international skill schools on the first and the second day, that is 29th and 30th. The residents in the room, the younger faculty members in the room, also the wise faculty members in the room. I invite everyone for the mega conclave in October. Thank you.
Thank you, Professor Vimal, for a very interesting topic. Any question from the audience? Yes, please, Dr. Abbas.
Maybe I can bring you on. Thank you very much for this fantastic talk. Thank you very much for the fantastic talk. Massive transfusion protocol and permissive hypotension is a kind of a misnomer, especially when it comes to anesthesiologists. When the blood pressure is low, you just fill them in. How do you change, how do you do that in your practice? What do you do to propagate permissive hypertension, not only in trauma, but also in medical patients?
Excellent question, sir. I think it's a difficult question. When you look at it from the perspective of a clinician or a resuscitationist, the permissive hypertension should have its precursor in preserving blood. So again, managing the circulation with hemorrhage control would take precedence. The second step would be checking whether you've got an acute spine injury, suspected, bar, predicted, checking whether you have an acute brain injury. If both of these are there, you don't think about permissive hypertension at all. You go ahead with filling the tank up with blood, like you rightly said. However, if you have a patient who's got no brain injury, no spine injury, a definitive aortic injury, or a definitive large vessel injury, definitive spleen, liver, or a definitive solid organ injury, you could definitely consider permissive hypertension quite early. Now, coming to your pertinent point on how much blood to give, when to initiate permissive hypertension, I think your blood pressure is guided by the amount of blood you give. With now point of care ultrasound that is available, you could maybe fill up the tank to an extent where you're getting a BP of a target BP as suggested by guidelines. For example, 2016 NICE said 80 to 85 systolic. There are guidelines which go even further down, but it depends on institutional protocol. What we depend on is an 80 systolic BP currently, 80 systolic BP currently.
Thank you.
Any other question?
It's time is up.
Yes, yes, Mr. Karan. Okay.
Thank you very much.
Just a quick question, sir. Just wait. Yeah, you go ahead.
Thank you very much for a nice presentation. Just, usually the patient, I'm talking about the multi-traumatic patients, they may come with also intra-abdominal pelvic hemorrhage and also intracranial hemorrhage. What do you think for the management of the hypotension, permissive hypotension, for the patient who has also intracranial pathology? We know the intracranial perfusion is really very important, crucial during the trauma. So we have to protect it. So for the patient who has both intra-abdominal or pelvic hemorrhage and also intracranial.
There's no confusion in the answer. Your first love will always never leave you, and brain should be your first love, not the heart. any other organ for that matter would take a second step. So if your brain is affected, if there is a massive traumatic brain injury, if I got your question correctly, and you've got concomitant other organ injuries, you just focus on taking permissive hypertension out of the equation and resuscitate, or rather over-resuscitate, I would say. Do not be stingy with giving blood products. Over-resuscitate, it should be fine, because you can de-resuscitate later. So the concept of de-resuscitation is coming in for trauma patients. The fatal effects of acute coagulopathy of traumatic shock is more than the effects of over-resuscitating with blood products. There are problems with both. However, the ECOTS or ETIC, early trauma-induced coagulopathy, could be more fatal compared to the other events. So maybe if you have traumatic brain injury with concomitant other injuries, do not consider permissive hypertension at all. Go ahead with resuscitation, rather I would say hyper-resuscitation.
Thank you, Vimal. That was a great one. And further, if you have any questions, we can, during the break, can discuss.
Thank you.
So thank you very
Thank you
much.
all for
Let's give a big round of applause to Dr. Vimal. Now I invite Dr. Nabil to the stage. He is a dedicated emergency physician, very passionate about his work. And he has mentioned the care is the main thing, compassionate care on the ground. He also have experience of establishing field hospitals as a forward field commander. Welcome, the stage is yours, Dr. Nabil.
Assalamu alaikum wa rahmatullahi wa barakatuh, and a very good morning. Thank you for the kind introduction. First of all, I would like to thank the committee, Prof. Bashar, Prof. Bechet, and the whole team for giving me this opportunity in this wonderful stage to present a bit on the Malaysian perspective of trauma systems and trauma centers. How do we optimize patient outcomes? So there's no conflict of interest. I have nothing to declare, right? So I would like to start off with this question. How do we develop a trauma system to optimize patient care in a resource-limited developing country? So just take into your thought of this question. And at the end of the day, maybe you can find the answer. So we have, of course, different chains of survival. Of course, we also need a good coordination between different stakeholders. So let's go on to trauma. So trauma is a global burden. I'm sure we have gone through this definition of trauma and the epidemiology of trauma in this past few days. And we know the leading cause of trauma is usually in the reproductive or the job-going age, which is the death below the 45 years old. We have more than 5 million deaths annually, according to WHO. And if you see the road traffic accident fatality in New South Wales and Australia, if you see the fatality is about 23 in 100,000, that was in the year 1980. They were able to bring it down with multiple protocols and different strategies, all the way down to 4.4 in the year 2019. So it is the #1 cause of death for the patients or the age group of 1 to 46. Okay, in Malaysia, the burden of injury is the 5th highest cause of mortality and is the #1 cause of mortality for non-communicable diseases in Malaysia. We have about 10% of principal cause of death in our Ministry of Health hospitals. And if you can see, majority of our trauma deaths are among the male population. So, if you can see, in Malaysia, we have 1 death every 90 minutes due to road traffic accidents. That's quite high. And if you can also see, the death fatality rate in Malaysia is about 23 in 100,000. That is higher than the world average of 17, and even higher in the middle income countries. And we are targeting to hope to one day achieve what is achieved by high income countries like the UK and Singapore. So this is one of the United Nations second decade action plan. So what was this is we are ensuring that we reduce the road deaths and serious injuries by 50% by the year 2030. So with this, I'm just going to talk to you about what is trauma system. So trauma system is a coordinated, regionalized network which is designed to provide a full spectrum of care, from the pre-hospital care to early resuscitation in the emergency room or ER, to damage control resuscitation, damage control surgery, to management in definitive care in the ICU, and subsequently rehabilitation and back into the society. So these systems are established to optimize the outcome of the patients. So of course, everybody knows the golden hour, early potentially preventable deaths. So let me come to the pertinent point of our presentation. The 3 strategic pillars that our country or Malaysia have instilled in ensuring our trauma systems are improved. One is the infrastructure and design, the second is the system development, and the third is clinical approach or competency training. So let's go one by one. What is the infrastructure or design that we are talking about? So we're talking about trauma resuscitation suites. So looking at building structures that mirror our service processes. So we can see multiple other centers having largely good equipped trauma resuscitation suites like in Melbourne, in Singapore, in UK, and even in Canada. So in Malaysia, we had our first trauma suite developed in the emergency and trauma department in Sungai Buloh, in Selangor. And this is based on all those protocols that we have talked about, step-down care, trauma alert, trauma approach, hybrid resuscitation, and all that. So the first thing that is important in making a good infrastructure is augmentation of your infrastructure and having a good workflow. And of course, repurposing existing or abandoned resources. So you optimize the resources that you have. You don't need to have a lot of economic power. You can do what you have. So in Sungai Buloh, we have a trauma resuscitation suite, and you can see the various types of areas like the warmer, the meds for the fridge, and etc. So we have a dedicated area so that trauma patients are triaged here and acutely resuscitated. So this is how an integrated, purpose-designed facility enables rapid, safe, advanced resuscitation for life and limb-threatening conditions. So this is one of the cases that we received in our emergency department, and we did an emergency thoracotomy, and subsequently the patient was saved. So emergency damage control resuscitation followed by damage control surgery. So in Malaysia, the mortality for these kind of situations was 100%. And now we were able to increase to a survivability to at least 25%. So I think that is a great achievement. So in my center, we've adapted the system and we've come up with a Selayang Hospital DCR suite. So you can see I'm there. So we had a patient coming in. We had 16 minutes of traumatic cardiac arrest. We did 16 minutes of CPR. We were able to revive him. We did bilateral finger thoracostomies. We resuscitated him with MTP and 6 pints of massive transfusions, and we have transferred him into the ICU and the OR. So he survived. So next would be the clinical approach and competency training. This is a very important domain. So we can look at the trauma care by clinical team approach. So different specialties, you need to target them with different competency training or trauma education. So you can see the senior emergency specialists. We have a subspecialty training in Malaysia, or what we call as a fellowship in trauma care. Then we have the emergency specialists, junior emergency specialists, or senior medical officers, where we allow them or we offer them a special interest clinical attachment program under the trauma fellowship, where it's about a 3-month program. Then we have for the regular medical officers, for the nurses, for the paramedics, we have Trauma Life Support Malaysia. And we also have a DAC or Advanced Diploma in Emergency Care in Trauma Care for the nursing. And finally, for the population, for the general public, we have interdisciplinary specialties. Also for the multidisciplinary units, we have National Trauma Series of CMEs, which we regularly do on a weekly basis. So we also talking about high fidelity trauma resuscitation procedures training. So what we have done is we have done human cadaveric workshops, like in 2002, so we can train better. Then we also have to identify what are the gaps. So we have found out discordant training syllabuses, variances in the training of provider competencies. We have found that there is absence of certification for these providers. And we have also found that there is no national registry or national provider registry. So all this, we have found a way or a strategic plan to how to improve this. So by having a clinical approach in training, by having a standardized national syllabus in terms of reviewance of the training program. So this is a nationalized standardized trauma training program. You can actually QR code and look at our trauma life support training systems. So it's academic free content. So we have standardized the evidence-based content and the training materials, and we have had a free academic content to everybody, and the student provider manual ebooks and also training videos. So this is very important to standardize the training throughout the country so that it is repeatable and reproducible. So this is the number of national trauma life supports that we've done until the year 2024. So we have a total of almost 4,000 trainers that has been trained the whole of Malaysia in terms of a reproducible, a standardized training system in trauma. So next is systems development, the last pillar. So in systems, we have multiple systems. I am sure we've gone through this, but we are going to just spend a bit more time on this. So first thing is implementing what we call as a pre-hospital trauma bypass system. So in Malaysia, we divert trauma patients to the nearest, most appropriate hospital versus the nearest hospital. This is to reduce the delays in transfer, to ensure a rapid, effective intervention, and to reduce wastage and improve outcomes. So we have implement trauma bypass system. Next, of course, implementing early administration of tranexamic acid. I am sure Dr. Vimal also has mentioned in the previous presentation, tranexamic acid has a lot of evidence out there, so there's no doubt that the early usage of tranexamic acid is vital in the care of trauma. So application of high quality evidence-based medicine into the local clinical practice, and this reduces the risk of traumatic hemorrhage and improves survival. Next, of course, we implement pre-hospital notifications and also what we call as a tiered trauma activation protocol. So what we mean by a tiered trauma activation protocol is we have a tier 1 and a tier 2 system, whereby in a tier 1, it is only at the level of ED trauma. So the resuscitation is actually led by the emergency physician. And subsequently, when the life-threatening conditions are identified, whereby we have completed our primary survey, then we can probably activate the tier 2 multi-specialty trauma teams. And you might wonder, why are we having this tier system? It is to avoid what we call desensitization. You must understand that when we actually activate tier systems on a regular basis, some multi-specialty teams, resources might be wasted and they might become sensitized to the trauma activation. Next, of course, is implementing a criteria-based whole-body pan-CT protocols for major trauma. So we improve the diagnostic capabilities and reduce the critical intervention time. So we reduce the fatally missed injuries with lethal complications. We know that there is sometimes hidden injuries, especially life-threatening hidden injuries that we might miss in major trauma if a pan-CT is not done. And these patients might initially be very stable, but subsequently, probably the next 12 to 24 hours, they might deteriorate, especially if these injuries are neglected. Then, of course, creating a national guidelines on advanced approach of massive transfusion protocols. I echo the thing that Dr. Bimal said in the previous presentation, where from massive transfusion protocol, we are probably going towards a massive hemorrhagic protocol. So in Malaysia, we also have a massive transfusion protocols. We use our local guidelines. So we enable rapid massive blood transfusion in life-threatening injuries. And of course, when we activate massive transfusion protocols, we must always remember to deactivate it as well. So at the end, we deactivate. So the way forward is a proposed cluster-based trauma care network. So we have adapted what happens in the London Trauma Office, where we have multiple trauma clusters. So we've adapted this system, and we are hoping to make that in the same in Malaysia. So Malaysia, we do not have a level 1, level 2, level 3. What we have is a major trauma center. So in cities like Kuala Lumpur, which is a major city where we have multiple major trauma centers, we are proposing a greater Klang Valley trauma system, where we have a trauma cluster coordinating center, and then we have a trauma treatment centers as well, similar to the London. So, lastly, we're talking about quality improvement. Everything when it comes, we need to talk about quality improvement. So how do we ensure quality is assured? So this is where we come up with developing a national clinical trauma registry. In 2020, we established a Malaysian trauma registry, and the preliminary results are supposed to be published this year in 2025. So this is building a data-driven trauma system, and it is targeted mainly to reduce financial implications for resource planning, and at the end of the day, it's about better outcomes and fewer preventable deaths. So you can see this is one of the quality improvement programs in our National Trauma Registry. We can see the discharge destination, the close outcome, what was the mean revised trauma scores, what was the main causes of death, what was the outcomes, etc. So this is very important for us to focus where is the places or the strategic points that we need to focus on. So lastly, what is the take-home point is trauma systems definitely save lives. A well-organized trauma system will definitely reduce mortality. It is a timely access to specialized care will improve patient outcomes. However, coordination between the multi-stakeholders very important. So with that, I would like to conclude, the trauma chain of survival is the most important part. Every chain is important, from the part of early activation, pre-hospital care, right until trauma rehabilitation. With that, thank you very much. I would like to acknowledge my professors, Dr. Shah Jahan and Professor Alwi, and of course, the Malaysian Society of Care of Trauma. These are my references. Sesekor Dirim. Don't forget, we have a fellowship and certificate in disaster medicine coming in Malaysia. And of course, we're having TopCom 2025 in Malaysia as well in July. And finally, Visit Malaysia here is next year, so please visit us. If you can't make it this year, please visit us next year. With that, thank you very much.
Great presentation, Dr. Nabil. I must commend you for that. For just brevity of time, catching up at time, we'll take questions after the next speaker. Thank you very much. Over to you, Dr. Almanian.
The next presentation from Professor Amin Ghazi. He is a professor of clinical emergency medicine with great experience in disaster and mass casualty management. Dr. Ghazi will present the WHO standard for mass casualty management, the lessons learned in Beirut. So please, Dr. Ghazi.
Thank you, professors, and thank you, EPAT, for giving me time to address another aspect of what I was discussing on the first day of the conference. As you know, yesterday I actually covered about 24 different lessons learned in mass casualty management in the emergency department based on the experience we have had over the last 20 or 30 years in Lebanon, in Beirut, at the American University of Beirut. So with the Beirut blast and others. Today, I have mentioned the fact that the WHO in 2023 came up with standards that have been promoted in different countries, at least a handful of countries across the world, through training of physicians and nurses and hospital administration in the concept of mass casualty management. The WHO academy, which published this material, WHO based this on the experience of ICRC, International Commission of the Red Cross, physicians who have worked in the field for the last 40 and 50 years. I've had the pleasure of working with some of them, Professor or Dr. Yankou from Greece, who basically worked in Lebanon, in Sabra, Shatila, in different war zones, and had the challenge of managing mass casualty management and conflict medicine. It contributed tremendously to the work that was published. I don't think it was published in a journal, but nevertheless, it's being taught across. We in Lebanon adopted this, thanks to the WHO, through a crisis unit at the Ministry of Health, whereby last year we spent a year training hospitals, physicians, administrators, nurses, training them in the concept of the promoted by WHO Academy. This training occurred in 120 hospitals. And that was possible because in Lebanon, up until September 2024, the skirmishes, raids, and attacks were more limited. It gave us the opportunity to train our physicians. And then they were tested. They were tested in September with you all heard about it, what is known as the pager attack. What is the actual objective of having such standards? Our objective is actually to avoid, finding ourselves functioning with being overwhelmed, finding ourselves functioning below the standard we want to have in dealing with an influx that is overwhelming our resources. The WHO standards focused. It's difficult to really not, to present the standards if you haven't really seen the lessons that I discussed the other day. I'll try to refresh them, but essentially they emphasize the need, and we agree with them, on crowd control. And crowd control isn't only external crowd control with people, populations, family members, companions, trying to break into the ED. Crowd control is also internal crowd control, whereby in your emergency department, you really cannot function when you have hundreds of people all flocking in trying to say, can I be useful? That doesn't work. So anybody who doesn't have a designated role has no reason to be inside the red zone. The green zone is kept away, and then you actually bring people in, but you only bring people in that you have asked and identified as needed. So no curious bystanders, no colleagues from the hospitals, only people that you really need. If you have a 40-bed ED and you have 200 red injuries inside your zone, and you have another 100 nurses and physicians in the ED, how can you function? Well, double that. Have 1,000 and see how it goes. If there are family members, rescuers, civil defense, people, administrators coming in just to walk around. We literally cannot identify who's there. I give you an idea about the Beirut blast in 2020. In 2020, we were all dressed in blue with masks and goggles because of COVID. We literally couldn't recognize who's what nurse, who's a nurse, who's a physician, who's the consultant. We literally were screaming in the room, do I have an orthopedist in the room? We couldn't really know our own colleagues in that crowd. So crowd control isn't only external, but it's internal, and you really need to have enough security measures and physical barriers to prevent that from happening, and graded barriers are necessary. Whether in the Palestinian camps, in our emergency departments, we have a gate outside and a gate inside, steel door, preferably not directly to the side of the road, not directly in the road, so that the ambulance or car doesn't drive through. Let it be lateral so they cannot actually hear it, because people have done that. They've driven through the gate. So you really have to plan accordingly your roads, your entrance, do it that way. You need to, the emphasis of WHO is to vacate in 3 steps. What does that mean? In the past, we used to allow, yesterday I mentioned it, the ambulances to come in, and then you have this stretcher that comes out and people in the room. If you're dealing with a situation with army and militia, etc., and bystanders from the community with a car blast or a bomb or air raid, the emotions are high. People put one wounded, sometimes 2 or 3 inside the ambulance. Some of them may be dead. And then they will climb inside the ambulance. So when you open the door, don't expect a rescuer with an injured patient. You're going to have a dozen people or half a dozen people pop out from the ambulance, grab the ambulance, and bystanders are going to grab that stretcher coming out and drive it through your barriers. I called them yesterday, 2 days ago, the human torpedo. It really is actually a steel torpedo driven by people going through. So physical barrier and human barrier. Everybody who comes in saying, am I needed, and tries to crowd you internally, put them outside. Tell them, yes, very good. Please, can you go smoke outside? And then they end up basically creating, with your security personnel, a barrier about 20, 30 people in front of the door that makes it more difficult for the torpedoes to injure anybody. They slow you down. So what the WHO recommended, it's a very smart idea, is that when we want to vacate the ED, we take all our stretchers and beds outside, because then you have empty rooms. And when the patients arrive, then, in the red, you put them on your own stretcher, preventing the stretcher of the ambulance to break in and then be needed inside, because it's a stretcher. They're going to go in. If they put their patient on your stretcher, they have no business going in to get their stretcher out. It's your stretcher going in. Of course, you need to have enough stretchers. But you vacate them outside, put them outside, and that will at least take half of the load. Remember, those very injured patients come with a bigger wave of tsunami. Yesterday, 2 days ago, I mentioned upside-down triage, what I meant the walk-in, the first hour, 45 minutes, are walk-in wounded. The second hour, after 45 minutes, really to be precise, they start coming, and the second hour will have the severely injured, typically the red ones, who are going to break through. You'll have some red ones, but within your capacity first. Then the second one is when you're going to get overwhelmed. It's a big wave, the big tsunami wave that you're going to have to deal with. By that time, your stretchers are outside and you're more ready to receive them. Create an emergency department buffer zone. What does that mean? In the past, we wanted to vacate the ED, so we assigned people to vacate it and look at the bed, go home, be admitted, over-admit, great, over-admit. And then call report. What do you mean call report? It means that now the floors want you to, just tell them who you're sending. No, you don't. What you do is you identify close to the elevator a zone where you take all your patients in the ED. Just move them all in there, and it's the responsibility of the floor teams to come and get them. No reports, come down, assess and move. Again, no report, come down, assess, look, ask if you want, but move them. It's their responsibility to take them off your hand, and that will free up your team to take care of what's coming. Buffer zone. And floor teams assuming the role of moving them up, including transportation. Critical, not critical, they go up. Assigning zone leads. I used to call them disaster medical officer, disaster nursing officer. They have better and more precise words. The resource lead and the clinical lead. Every zone, red and green, will have a clinical lead and resource lead. Now, a resource lead can be a nurse. Yes, of course, senior nurse in your department who knows what she or he needs. The clinical lead is a physician who basically will be the one deciding who goes to the OR, who is palliative, who is yellow and needs to be admitted to be operated on later. And there is an incident commander that is actually looking at everything. The WHO talks about one incident commander, but in big institutions like tertiary care centers, our experience is you need 2 incident commanders. One in the ED, who's an incident commander overlooking what's going on with the clinical lead and resource lead. Neither of those 3 should be involved in taking care of patients. They're just doing the job of overseeing the flow is correct and decisions are made appropriately. They need to know what's inside every section. And they need to overlook those 40 patients and get an idea what to prioritize, who's needed, what extra resources do we need, what's going on in the big picture. These individuals, and I'm here referring to tertiary care centers, not single small EDs with a single staff, where it's a different story, which the actual WHO focused on. In bigger situations, you need 2 incident commanders, one within the institution and one down in the ED. And I will show you an example of how is that needed. Last but not least, color jackets. In the past, we used to have small tags, little yellow, plastic tags we put on our chest. Those big jackets, that's what you need with color jackets to identify. Why is that needed? I'll show you in a moment why. So, they also emphasize the fact that there is no such thing like a category yellow when they arrive. You're either green to the green zone or red, you come in. If you're not walking, that means something is wrong with you. Either your pulse is not adequate to perfuse your brain so that you can function. If you're in distress, cardiopulmonary distress, if you're neurologically having instability, you're usually carried. So anybody carried would be brought in, and everybody who walks goes to the green zone, which is kept outside the ED. Not in no ED, but outside. So pre-planning this within the institution. What pediatric ambulatory clinic, you're gonna move them to, typically away 50, 100 meters away from your ED, with a separate entrance. And they take it a step higher, whereby when you identify yellow, it's a step 2 triage done inside the ED, and the step 2 triage is by assessing patients. Those who need to be admitted, they are identified as yellow. Those who need to go to the OR because of that imminent need for it are become red, and they go straight to the OR. There is a blue category for palliative care. The patients that we call black, those you decide cannot be saved, major burns, severe brain injury. We're not doing thoracotomies that day. So those patients, they're palliative. They're basically sent to the floor as blue, one designated area where morphine is being used. And families are allowed to say, come and say goodbye. That's a different story anyway. So you have a two-step triage. Step 1 is when you are outside and saying, you're green, you're red, you're green, you're red. Step 2 is when you're assessing every patient to decide what needs to be done. You need directional flow. Is that basically once you head towards the green zone, there are no patients coming back. If in a step 2 in the green zone, you identify a patient needs admission, because you will do a second assessment, that's a better assessment. Those patients will need to go into the ED from a back door. So you need directional flow. You want to avoid any patients going back and forth. Go and don't come back. The buffer zone is identified, and a team approach in doing step 2 triage that is either a pit or rotational. And the difference is that basically when you have a multitude of patients and you have teams of nurse physician to assess these patients, you either bring the patient to one station where they're assessed, or you have a rotation of the team going from room to room to identify, to execute the team to the step 2 triage and start administering care. So care is administered either through a rotational perspective or through a pit. And the pit is the area where you provide care for these patients. It's a strategic decision for the clinical lead to plan and execute in your institution, depending on how many teams you have. Because the big assumption always in disaster is that your resources are overwhelmed, you're diverting the green away, and you have the red available to do what? To provide care. But if you don't have enough red teams, what do you do? Until you have enough to handle the patients you have, you need to use either a pit or rotational approach and create these units that can provide this care in the red zone. The green zone can wait. So, as I mentioned, and I already discussed this, small hospitals versus large hospitals, honestly, is something that the WHO will need to work on, and that feedback is being provided already to them. So we mentioned that there is no yellow, you maintain unidirectional flow, unrestricted for patients, and the WHO says strictly no companions. Strictly no companions, except with very small children, where they advocate to allow one parent to go in to act like a surrogate patient and stay with the pediatric patient. They promote the concept of no CPR. Any patient who passes away or arrests, you don't do CPR. This is not a time to code, they're dead. No radiology, no CT, no X-ray, clinical judgment. You think they need a chest tube? Put a chest tube. No lab testing. You're not doing tests on these patients. You're just deciding yellow to the floor, red to the OR, and green to the green zone. That's what they advocate. In the Beirut blast, we did not use these principles. We had 3 CT scanners functioning, and in front of every CT scanner, we had 25 to 30 patients in line. Managing these patients who are now waiting to have these scanners at any time getting done, and X-rays getting done, caused us another issue where we had to re-evaluate who's in line and who's a bigger priority. And we had patients crash while waiting for the scanner. So this is why they do what they do. They're saying, do not rely on studies, rely on clinical judgment and decide who goes to the OR and do it accordingly. They don't do what I'd recommended, whereby we talked about the level 1 and level 2 activation and the mobilization part. They are doing and advocate what is necessary for smaller hospitals. So you're either activating or you don't. In big institutions where the activation of a whole staff means a couple of thousand people showing up, it's a different story. So you really should, and when I gave them the criticism, the approach, the response was, you're right, but this doesn't go against this. Consider it, it's not about pushing a button, because they think that there is just a button you push. It's not about a button, it's about being able to have redundant ways of reaching out to people. And as I mentioned yesterday, the use of Wi-Fi and WhatsApp or Signal is very essential to be able to notify your people, because all other means of communications will have problems. Dulci Bellum in Expertise, which is by Erasmus, which says, there is nothing glorious about war. Those who have the experience of it know that very well. Any questions? Thank you.
Thank you, Professor Ghazi. Any question? Yes, Dr. Veman.
Hello. Yeah. Excellent session, Professor Kasi. Just had a quick query. You spoke about unidirectional patient flow here. Day before yesterday, there was one session where you spoke about single door entry and exit, so for the patients. So when there is a unidirectional patient flow, you can't have a single door entry and exit. Could you elaborate on the same? Because the WHO guidelines said unidirectional flow.
I'm not sure I understand what the full question is, but I'll give you my answer. Your question is basically, how do you maintain unidirectional flow when you have a single exit and single entry?
Correct.
Single exit and single entry is for the ED. Your ED is a red zone. All the other patients are diverted in one direction towards the green area, which is away from the ED. So the WHO is recommending not to create your green zone within your ED. They're creating it in an ambulatory care setting, maybe another building even, that's just outside the area of your ED. Preferably one where there are, you already have the equipment, the supply carts that you've deployed. I actually, unfortunately, I think we've used the wrong file because I had some films to show you from the pager attack. And I think it's difficult for me now to activate it. But nevertheless, what I would like to tell you is that when they arrived, we had over 1,000 people in front of me. I was the one at triage. We received 190 injuries. And the difference, remember also one of the lessons I said yesterday was, when you think you are ready, you're going to be surprised. When we thought that the maximum is 300 injuries, we had 700 with the ammonium nitrate. When we thought we knew what to do with 700, we had somebody break the rule. What was the rule? The rule is 70% of all mass casualties, 70 to 80% of all injuries in a blast or a mass casualty event typically are walk-in wounded. Well, the day of the pager attack, there were it wasn't a bomb, it was 3,000 bombs. So 3,000 bombs was so unexpected, small bombs, but nevertheless, causing 90% of our patients required surgery. So suddenly, we have, out of 190 people I received in my institution, the largest number, we have 40 hospitals in Beirut, so you imagine we diffuse them everywhere. But 190 were received. We had less than 14 that were green. Everybody had hand, leg, torso injury. People who did not open the pager, they had it on their side in their pocket. You can imagine what happened to them. Some of them had neck injuries, brain injuries, but mainly eyes and limbs. So eyes and limbs, they were talking amputations. So these patients we had 180 red, which is unexpected. So what was the key of our success? We brought them in, and a triage, I had the red, they were being carried. Anybody who's stuporous, anybody with respiratory distress was staying in the ED, so there was red within the red. I was providing the step 2 triage to some extent, as directing them. And anybody who obviously needed OR, but not now, within the next few hours, I was being sent to the floors. So we augmented our capacity. And the key element of the WHO is that because they are the WHO, they were able to get our hospital administration, meaning CMO, Chief of Staff, Chair of Surgery, forced for accreditation purposes to attend the meeting. So they became involved. And so we actually opened 3 floors to become acute care units where all those reds went up. So we augmented the capacity. So instead of having hundreds of our colleagues coming into the ED, pushing to come and help and cluttering us, we expanded them into the floors. So you had the intensivists and the surgeons and everybody on different floors. Pediatric intensivists, they were running the show in their areas. 3 different areas outside the ED on the 4th floor, 5th floor, that basically were expanding, where the endoscopy unit became a small little intensive care unit. You know what I mean? So they used the resources, and we expanded our facility, expanding the space for our red zone. This engagement of our colleagues and a change of frame of mind, so that we are not owning the process, but expanding the process to include them. This inclusive approach, advocated by the WHO and reinforced by the Ministry of Health through accreditation initiatives, allowed us to be able to function and be able to do what we otherwise would have been overwhelmed. 180 red patients is different than 40 and 80. So now, I mentioned the directional because there is one entrance. So all the reds went through. The second part of it was the issue of companions. I mentioned yesterday that when you have a blast, many patients will look the same. It's very difficult to remember. Can you imagine riots with tear gas and knives and sticks? They're male mainly, and they're all within an age range 15 to 30. So what are you going to expect? How do you really differentiate between one and the other? In our experience, having a surrogate with them actually helps us identify that this is the right patient and what the plan is. Very important to have it. Plus, it's easy for a planner to say we will have additional stretcher bearers. Stretcher bearers and stretchers, somebody has to walk the patient, put them in a wheelchair, put them on a stretcher and move them. Do you have enough people for 180? How many stretcher bearers do you have? So a companion going in, can you imagine in Lebanon trying to tell the militias of Hezbollah that basically you're not going to be allowed in with the injured person who's typically somebody important in their militia? No, they wanted to go in. So instead of having 10 people go in, we actually auto-delegated to them, like yesterday I mentioned, who's in charge over here. So we had 4 of them, 4 of their leaders, because they don't all even know each other, but have enough authority to say only this person goes with them. So we limited the number of companions, and that may actually have helped us rather than hurt us. Then we took some family members into those units, and we created a waiting area up there to relieve them. So you cannot always not be flexible. You have to have some degree of flexibility. And in our situation, taking those security decisions whereby to allow a companion and to accompany They actually cause less problems. Do you imagine having 200 people all injured, severely injured, having 2,000 people, their relatives, outside trying to break in to check on them? You're gonna tell them, wait for 6 hours outside? You're gonna be injured. So the safety of your team is essential. So set your objectives and set your approach and be flexible but firm, okay?
Dr. Hassan.
Dr. Kasi,
Yes.
thank you. Excellent presentation. My question here, when you have a group of people, you train them for the WHO mass casualty training, what is the percentage of retention of knowledge for this group following that exercise? Thank you.
I'm sorry, Dr. Al-Thani, I may not have understood the question very
No, the
well. What is the
question-
percentage of?
The question is, in your opinion, if you have a group of people who go through this exercise of a training with the WHO, what is the knowledge retained after that exercise by the group?
Very, very important questions, Dr. Al-Thani. In our prior attempts, we used 3 other strategies where we sent trainers to train the physicians in Lebanon. So again, I'm the physician representative, so I really was selecting the surgeons and emergency physicians and nurses who went to hospitals to train. And it was to our big disappointment when they would show up to train people on basic principles of trauma and ED management in mass casualty. People showing up were very limited people, but there was little compliance and interest. And I suspect many of the people, lessons learned were not acquired. However, so there is a lot of frustration, and really, the real people who get involved in training the trainer missions many times realize that many people don't show up, and even if they show up, they may spend their time smoking or on their phones. So, I mean, we really have that challenge. But when we did 2 days of training to all hospitals and required it through accreditation to have the hospital chief medical officer and the decision maker, the chair of surgery, the chair of show up, we had their buy-in in expanding. Merely because we have the buy-in to expand, some of the key lessons that we needed to advocate and push went through. I must say, Dr. Al-Thani, that part worked. It really worked. And because, remember, we had the Beirut blast, and we had now the pager attack, and we see and felt the difference. As a matter of fact, less conflict between teams, more comfort in having delivered the right care, barely any challenges. The challenges we had, honestly, were more so due to the ocular injuries. You know, a lot of people lost their eyes. And the question was, could you have done something more for them had you operated faster? How many ophthalmologists exist, and how many of them can go straight to the OR for an eye injury? And how much of an eye can you save? And how quickly can you do that when you have, 1 or 3 ophthalmologists willing to go to OR? We actually used our obstetric rooms, the OR, when we do C-sections. We used all our minor surgery OR, everything was opened up to take care of all these patients, and we expanded the capacity. There were other issues pertaining to, once you have received that number, should we have been able to use other hospitals outside Beirut to help us alleviate the operations that we had? We were operating for 4 days. A lot of, So this is another aspect of it, but that was not the mass casualty management plan at the beginning. Yes?
We already exceeded a bit of 5 minutes, into the tea break. So if you have more, please catch up with Dr. Kazi. And always a pleasure to hear you, sir. Brilliant speech, lecture. It was really amazing, sharing the experience of Dr. Kazi. And let's give him a big round of applause to sir.
Thank you. I'm here if you have any questions. This is a topic that for many of you, all of you, is very important, I know. And I'm honored to have the opportunity to discuss this with you. Thank you.
Acaba o kadar olmuş mu?
You got me, baby.
Kalibre ediyor mu?
You got what I need. You got me, baby.
Aynısı değil mi?
You got what I need.
Pardon, kameramı takip tepe kaydediyor. Bak kalibre ediyor mu?
You got me, baby. You got what I
Kafa
need.
yanılıyoruz ya, kalibre etmeyebilirim.
You got me, baby.
Geçen
You
haftadan
got
daha
what
fazla
I need.
kafa geldi.
You got me, baby.
Bastırdık bir şey yapmıyorsun ki yani. Ekranı gördüğün zaten çıkıyor şeyde. Aydın hepsi. Yapışmaz zaten adam. Sen değil. Levent Bey. Levent Bey. Okul 3 hayırlı olsun. Okul 3 hayırlı olsun. Okul 3 diyorum hayırlı olsun. Arkadaşlar okul var benim. Hiç mi alacaksın? Ben değil de ben sol kamera salmam lazım. Ya bir şey alacağım. DJI Action alacağım. Action 5. Ben onunla geçen sene çekerken şata basamıyordum suyun altında. Bazı temasları var. Çok otomatik. Hadi ya. Şey çıkardık ya. O başlarda var. Tamam. Affedersiniz olur.
Sight of your little game has been activating. Why not? I'm a slayer, ain't no saying. Yeah, I'm talking about why not? I just want you to say my name. Say my name. Say my name.
Ses deneme. Ses. Ses.
don't see here. I'm sorry. Okay. I'm sorry. I have the other. Do you have?
I think this is probably the first speaker, yeah.
Okay, so maybe I introduce the Paul and after then him, or you will?
Okay, I'll start.
Okay, you will start.
Okay, we will.
Second.
Good morning, ladies. It's not on.
It's working.
Good morning, ladies and gentlemen. We will start immediately the session as it is. We are late by 5 minutes. So we will start the first presentation by Dr. Linu Sekar. Is he here? Yes, thank you. So the title of his talk today is Magnesium Levels in Acute Coronary Syndrome.
Version of this. Thanks.
Good morning. I thank WASM and IPAD for giving me the opportunity to present whatever I could find out in my institute during our research. So I'm going to talk to you about something which is not very rare. It's already known, some things. It's about the magnesium levels in acute coronary syndrome. So why is magnesium important? So as part of emergency physician job profile, all ACS are high-risk presentations, which warrants a lot of decision-making and risks. And magnesium has been studied extensively, and it is known that it is very vital in cardiac electrophysiology and maintaining vascular tone. It has been implicated in pathogenesis of ACS and its complications as well, including arrhythmias. And it modulates other electrolytes like potassium and calcium as well. And there are recent reports that there can be functional deficiency of the normal magnesium levels in the body during an ACS attack, and maybe that will add on to the alteration in the magnesium levels which we may see with acute coronary syndrome patients. So what we did was we studied about 150 patients who had presented with acute coronary syndrome within 48 hours of symptom onset. We measured their magnesium, sodium, potassium, calcium, as well as the routine troponins on day 1 and day 5 of admission. And we included all types of ACS, including recurrent MI. So what we could find out in our study was that close to 60% of patients which we had studied had a normal, either a low magnesium or a low normal magnesium in the range of 1.8 to 1.9 milligram per deciliter. And the mean admission levels of magnesium was 1.78, whereas by day 5, it either improved or due to supplementation, it rose up to 2.32. And we found out that a higher risk ACS stratified by the heart score, which we used in the study for all study patients, had a significant lower magnesium levels. And hence, we may think that lower magnesium was associated with greater disease severity in our cohort. Regarding ACS subtype, almost all subtypes had no much difference. There was no notable difference between STEMI or NSTEMI. But what we found out that in recurrent myocardial infarction patients, the magnesium levels were even lower. And in posterior wall myocardial infarction, we found out that magnesium levels were the lowest among the different walls involved. And we also tried to find out whether there is any correlation with these magnesium levels and other electrolytes. We could find out a minor positive correlation with sodium, meaning that if magnesium is lower, sodium is also lower, and if levels are altered, sodium levels were also altered. So of late, after 2015, we are having a few studies. The largest study, which was published in Journal of American College of Cardiology in 2017, included around 11,000 patients, where they found out that there was a U-shaped risk, meaning that magnesium levels more than 3 and less than 2 had adverse outcomes for ACS patients. So the other studies were Lal et al. And Ekla et al. They were low population studies which came from India and Asia, which showed that lower levels of magnesium in the time of admission had adverse outcomes. So these were those studies, and in 2023 we got a study from Middle East which shows that magnesium levels again affected the outcome of the patient in an adverse fashion. So of late, after 2015, we are having many studies which says that magnesium levels may be detrimental in ACS outcome, contrary to the earlier belief. And now we go into magnesium and arrhythmias. So it's a known fact that it stabilizes membranes and support positive potassium balance. And if you give IV magnesium during ACS attack, usually the reperfusion arrhythmias and the next arrhythmias which come in first 24 hours are lesser. So current guidelines but focus on the fact that you need not supplement magnesium for every patient. You can supplement it in patients who are having lower magnesium levels at admission. But the robust evidences are already there which shows that routine supplementation of magnesium is not needed. Based on few RCTs and the MAGIC trial and Limit 2 study, which came out as early as in 1994, they found out that routine supplementation, it means that without checking magnesium, you need not supplement magnesium in ACS patients. That's based on those guidelines, current evidence, including be it American Heart Association or ESC guidelines, they do not warrant routine supplementation of magnesium. So this study which came in JAMA in 2006 had earlier identified about hyponatremia and the adverse outcomes. Now, hyponatremia can be adversely affecting the ACS patients, and this has been reiterated in our study also, and we found out that lower magnesium level patients may have lower sodium levels as well. So coming to some comparison between troponin, we can never compare magnesium to troponin, but we can just tell that magnesium has got an add-on value. It may have an adjunctive value or prognostic value. And because in our study itself, we had patients who had ACS but normal magnesium levels, or patients having hypomagnesemia but having ACS. So we cannot tell that it is a rule-out criteria. We can just suggest that it is an add-on criteria to our already armamentarium of biomarkers which we do have. So the current take of guidelines on magnesium is that it should not be supplemented prophylactically, but it can be supplemented if you suspect arrhythmias or if you have an already documented low magnesium levels. But now comes the problem here. How many of us do magnesium routinely? So in my institute, before this study, we do not used to do routinely magnesium for all ACS patients. We used to do ECG, drops, and maybe sodium potassium at the max. Magnesium was not even suggested by the cardiologist some 7 to 8 years back. But on finding out what was the reason, we do not have robust guidelines telling that all ACS patients should have their magnesium checked. In a large registry, 63% of MI patients had magnesium measured, and a large hospital-to-hospital variability. Some hospitals measure only in about 10% of ACS patients, but in some others, in 98% of patients, these hospitals measure magnesium in ACS patients. So this leads to something called as an institution-level protocol instead of guideline formulated protocol. And these are the current guidelines which I had taken. And these are the snapshots of the articles, this Limit 2 trial as well as the MAGIC trial, where they had extensively studied way back in 1994, and they considered giving magnesium, was there any benefit in giving magnesium to all patients who can come up with ACS? But unfortunately, they could not find out a positive benefit, and that's why the guidelines do not recommend magnesium yet. This was a summary of these. Again, they revisited these RCTs, whether there was any scope of including the magnesium of late, but they couldn't find anything. So that's where we stand. In summary, what I found out in my study and from few studies which had been published after 2015 is that we cannot ignore magnesium. Magnesium does matter in acute coronary syndrome, and levels less than 1.8 milligram per deciliter are commonly linked to complications like arrhythmias. And the prognostic role has been supported by multiple studies, in fact. It's not yet diagnostic, but it's a useful adjunct. And the 2023 recent guidelines also do not, ESC guidelines also do not incorporate magnesium into the biomarker panel. It means that we need more studies in this area to decide on whether we should do magnesium in all patients or selective patients or patients who have more disease severity. So for the emergency physicians, magnesium matters, and ensure that your ACS patients have a normal magnesium levels during their ED presentation and inpatient course. And we have to recognize that abnormal magnesium might signal higher risk, so you can mobilize telemetry, correct the deficiency, and consider involving cardiology if severe hypomagnesemia is present. And for now, I would suggest to use magnesium levels wisely as a tool to improve the acute care and safety of our ACS patients, and probably wait for more robust studies, more multicentric studies and RCTs to rethink whether magnesium is again important in ACS. So this is our published literature. We published that study, and I'm open for any questions.
Thank you, Professor, for this interesting presentation. We will address all questions during the joint discussion at the end of the session. Thank you.
Okay, so I bring greetings from my institute. This is where I work in Kerala in India. Thank you.
Thank you so much. Please join me in welcoming the second speaker, Dr. Paul Kivela, who will now present his lecture titled An Algorithmic Approach to Syncope. Dr. Kivela is a clinical professor at the University of Alabama and a past president of American College of Emergency Physicians.
Salamun alaikum. I'm going to get it right one of these days. Well, thank you very much again for having me here. It's an honor to present. And I'm going to give a much more simple presentation here than some of the previous speakers, but it's important nonetheless. Over time, I don't have any disclosures, but over time, I've looked at a lot of things in the United States where we get lawsuit and sued. And one of the big problems where we get sued is over this diagnosis of syncope. And I'll go over some of the mistakes that we have, and it's not a knowledge mistake. You know, everybody knows this, and after the lawsuit is done, after we ask the doctors, you know, what did you think about this whole thing? And the issue that the physician said was, I don't know how I missed the diagnosis. So I'm going to talk about a little bit of, I'm not going to get too deep into this, and just go straight to the presentation of what we know and how I approach syncope now in a very algorithmic approach. So the incidence of syncope is relatively common. Over the lifetime, it's up to 40% of certainly people in the study worldwide have passed out, have lost consciousness. And of course, the mortality is very, very high if it's cardiac, but it's even significant if it's not cardiac. And the problem that we have is we admit these people oftentimes to the hospital, and after the discharge from the hospital, which the average length of stay is 5.5 days in the United States, almost 1/3 of them still don't have a diagnosis. So we still don't know. And so that leads to a lot of potential problems. The differential is pretty broad for syncope. This is kind of the list of what you really cannot miss. And so for those of you, my students in the United States would tell you, and it may not translate to all their languages, but I do things alphabetically. So it's A, B, C, D, E, F, G, H, I. So that makes it a lot easier for me to remember than some very long mnemonic. And I carry these diagnoses oftentimes on my phone so that before I send this person home, I ask myself one more time, have I missed any of these diagnoses? And I literally go down this list like a checklist. And so one of the biggest problems that we have is something called the tyranny of choice. And what happens here is that if you have too many choices, you can't make a decision. So even as emergency physicians and physicians, we're pretty good. We can often consider 5 to 7 choices at a time, where the general population is really at 3 choices, that once you have more than 3 choices, it's hard to make a decision. You go to a restaurant, and particularly for a big dinner, did they ever give you 7 choices, 10 choices? No. The restaurants have learned. They give you 3 choices, so it's easy to make a decision. But we, again, in emergency medicine have way too many choices. Certainly there's the San Francisco syncope rule. There is obviously, this rule has been in existence. The problem is that this rule was initially said, oh, we're not going to miss anything. Well, they've tried to repeat this study, and the syncope rule certainly does not work necessarily. There's also the Canadian syncope score, and this is a little bit more extensive. But again, as you look through the diagnosis list that I have, things that you can't miss in syncope, this list is not necessarily helpful as well. So, of course, you know, I go down the same list here of asking myself certain questions on the history of what were the circumstances. Sometimes that points us in the right directions. How long was the person unconscious for? That can help. Was there a prodrome? Did they feel something before this happened? Was there confusion, like a postictal, that it was a seizure? Were there injuries? Or did the person just literally fall to the ground? And then was there shortness of breath? Is there a history of heart disease, congestive heart failure? And is there either high or low blood pressure? The physical exam, again here it's, you know, the vital signs are very, very important. The head exam, is there head trauma? Is there internal mouth trauma, like they bit their tongue? Neck, you know, was this, you know, was there any abnormality, you know, JVD? Chest, is there chest trauma? Breast sounds, you know, what do the breast sounds sound like? Cardiac exam, is there evidence of aortic stenosis? Abdominal exam, you know, is there tenderness there? Is it distended? Vascular exam can be very important, particularly with an aortic dissection, checking your pulses in all 4 extremities. Neurologic, certainly. Orthopedic, did they injure themselves when they fall, or did they just have a bad knee and they didn't really syncopize, their knee gave out? And of course, skin, looking for any evidence of any rashes, infections, or other problems. The approach to the EKG, again, you'll notice I'm a very alphabetical person. I like to do things in a certain order. Here it's rate, rhythm. I look at the QRS wide narrow. I look at the ST segments, look for U waves, extraventricular beats, which axis is the patient, and any type of blocks. So that's how I think about this to make sure that I'm looking at this in the right form. And then when I go to syncope, I came to this conference several years ago and Dr. Brugada was here. And he scared the heck out of me. I would always look for Brugada A, but I didn't realize there was a type 2 and a type 3 Brugada. I came back home thinking about epsilon waves, which I've now seen 3 times, which I didn't even know existed. So this is how I go through the syncope, is I certainly look at the EKG for a heart attack, but now if it's in syncope, I go through this again in a very algorithmic way. I slow it down, I look at the EKG, am I missing any one of those aspects? And this is a whole nother lecture that I've given here on looking at the syncope EKG, but this is an important thing to think about. Focus labs, there really isn't a lot of labs it's mostly history, it's mostly physical. But of course, glucose, CBC, electrolytes, renal function are very, very important. Looking at troponin D-dimer pregnancy test also in certain patients may be important. The focused radiologic studies, certainly the echocardiogram is something that you may want to consider in all these patients. As we have ultrasound at a bedside, we're doing that. The emergency physician is doing that these days, which is a big advance. Chest X-ray, a CT scan, an ultrasound of the abdomen. Is there blood in the abdomen? Sometimes that's helpful. Is there a potential ectopic pregnancy? And again, one of the diagnoses that I've found very commonly that now that I go through this algorithmic approach, it's amazing how many times pulmonary embolus ends up being the diagnosis. And that's something that we really, as emergency physicians, cannot miss. Again, this is my list. This is my checklist. This is my do not miss list. I encourage you all to, whether it's my list or your own list, is to go through this, to take advantage of this, of making sure that there's not something that you're missing. Thank you very much. I think there will be some questions at the end, but I appreciate your time and I appreciate the honor of being here in Turkey with all of you from Turkey and around the world. Thank you very much.
Thank you, Paul, for the wonderful talk. We have the question and answers at the end of the session. Thank you. With that, without further ado, we will invite the next speaker, Dr. Ayman El-Manya. Thank you very much.
Good morning. My name is Ayman from Doha, Qatar. I would like to talk about the BRASH syndrome, cardiorenal cross-talking in the emergency setting. I have nothing to disclose. The BRASH syndrome is a relatively new syndrome in cardiology and emergency. It is maybe reported in 2010. So it is mainly a link between the cardiology, renal, and emergency. So it is a clinical diagnosis defined as vicious circle of medication-induced AV nodal blockade. So vicious circle mandate the presence of medicine as a cause, and then the outcome is AV block, heart block, and it goes through the renal impairment and hyperkalemia. So it can start with a patient who has a beta blocker or calcium channel blocker, which causes bradycardia in terms of junctional escape rhythm, sinus bradycardia, heart block. This is the order of which one is more common. So bradycardia will cause renal malperfusion and acute renal injury. This will cause renal impairment. Renal impairment, of course, can cause hyperkalemia. Hyperkalemia itself can cause bradycardia. And this is a vicious circle. The outcome here will be the circulatory collapse due to the severe bradycardia and shock and the organ failure. So this is the circle that we should be aware about it. So the pathophysiology also can be related to the use of AC inhibitor or ARB, which can cause also renal impairment and also cause of hyperkalemia. So the renal impairment will reduce the clearance of the beta blocker. If the patient is taking beta blocker, the clearance of the beta blocker will be reduced. So they will cause accumulation of the beta blocker in the body. This will also affect more the conductive system in the heart. And also there is some non-selective beta blocker rarely can cause hyperkalemia. So the renal impairment cause hyperkalemia, as I said, due to this medication. The bradycardia will be the outcome. Then again, the outcome will cause more malperfusion in the kidney and more renal failure and more bradycardia and so on. So The excessive AV node block intensified by hyperkalemia, which is synergistically impair the AV conduction. So not all the patient with beta blocker and not all the patient hyperkalemia alone can have this problem, but the combination will cause synergistically cause the AV block. This will be due to depolarization and cardiac myocyte sodium channel inactivation with marked bradycardia and low cardiac output. Then again, the hypoperfusion and the potassium and the AV block agent, and this will be due to the impaired clearance of the beta blocker and the accumulation in the beta blocker, and so on. So from where we get information about the Barrage syndrome, it is mainly from case reports, sporadic cases. There is no well-established study about the Barrage syndrome. So there is two systematic review in the literature. They are trying to collect data about Barrage syndrome. As you can see, the first systematic review found only 70 cases, not 70 study. And the second was 34 cases. So mainly, we are getting information from a sporadic case report. And from this two review, we learn about what is a precipitating agent. As we mentioned, beta blocker is the main one. And from beta blocker, the metoprolol is the main offender. Also, calcium channel blocker, especially diltiazem, had impact and has a role on the Barrage syndrome. The ACE inhibitor, of course, can cause it. And other than this, we can get the look for the amiodarone is also a reason for Barrage syndrome in some cases. And of course, in some cases, where hyperkalemia will be induced. From this also review, they find that what is the ECG finding of the Barrage syndrome? In 1/3 of the cases, it is junctional bradycardia, and about 1/4 the sinus bradycardia, and 12% complete heart block. And 10% is atrial fibrillation. Atrial fibrillation by itself is not the cause, but sometimes in some patients, atrial fibrillation will cause a slow ventricular response and the bradycardia at the same time. The minimum median heart rate in Barrage syndrome patient is 35, which you can say this is significant bradycardia. The laboratory finding for Barrage syndrome, we can see that the median serum potassium is 6.3. It is not so severe. The median blood urea and the creatinine also is mildly elevated. Demographic and comorbidity of this patient, the age, the average age is about 70 years old, and it is mainly in the male, which is more than 52% for Barrage syndrome patients are male, and 48% female. All patients had at least one comorbidity, but 1/4 had two comorbidity, and more than half of the patients sometimes have 3 or more comorbidity. The most common comorbidity is hypertension, because this patient, of course, will use more medication like beta blocker and the ACE inhibitor. Diabetes also is a reason. Atrial fibrillation in some cases, because atrial fibrillation patient, of course, they are using either beta blocker, calcium channel blocker, amiodarone in the treatment, digoxin, so this can lead to bradycardia. What is the most common presentation of Barrage syndrome is the syncope and general weakness, mental status alternation, and more than or about 3/4 of those patients need intensive care admission. Cardiac arrest can happen in 10% of this patient. Mortality is about 7%. 7% of this patient. So what is the treatment of Barrage syndrome? Mostly these patients need entropes like dopamine. They need also atropine, glucagon, and hemodialysis. And we, of course, know glucagon is one of the treatment of beta blocker overdose. Also, you can see in the ECG, one of the treatment is the temporary pacemaker. In Barrage syndrome, 1/3 of the patient require temporary pacemaker, but fortunately, no one will need permanent pacemaker. And some claim that calcium channel blocker can be used In this patient, when the situation resolved, you can replace beta blocker with calcium channel blocker, but there is no strong evidence about this. They said also metoprolol, although it is one of the causes, but sometimes because it's lipophilic, it metabolized by the liver, not affected, not excreted or metabolized by, not metabolized by the kidney, so it can be used. This is some case presentation and to see what is the situation or how the breast syndrome can occur. This is the patient with recurrent syncope, and you have to look for the medication in this patient. As we know from the previous presentation about syncope, medication is important. Verapamil and lisinopril also in the two offender of breast syndrome were used in this patient. Blood pressure was 90/40, heart rate was 30. You can see about this, you can see, look to this ECG, and from the lab, the potassium is high, creatinine is high. Patient was treated with atropine, insulin with dextrose, calcium gluconate, and the most important is to stop all the previous medication. And bradycardia, hypotension gradually resolved, and the pacemaker was not used. This is another patient who came with out-of-hospital cardiac arrest. This patient, history, they found that he is using metoprolol and lisinopril. So CPR done, he survived, and ECG showed junctional rhythm with heart rate about 30, and he treated by calcium gluconate, insulin, Lasix, and the IV fluid. And of course, they stopped metoprolol and the lisinopril. We can see in the table the creatinine and the potassium were high. This another patient who was lethargic, and the heart rate was only 23, although the blood pressure was maintained. And he was found to have amlodipine, one of the calcium channel blocker, and furosemide. So this can cause renal impairment and also hyperkalemia. Creatinine was high, and potassium was only 5.8. Troponin was negative, and he was treated by atropine, which make the heart rate up to 46. In this case, we learned that breast syndrome can be triggered by some event. In this patient, it was due to dehydration from using Lasix. And the potassium in breast syndrome is only mildly elevated. You will not see in all patients severe hyperkalemia. So because of this mildly elevated, in the presence of the beta blocker, breast syndrome can happen. The treatment, as we said, you have to lower the potassium, improve the linear function by fluid, and of course, to deal with the bradycardia. Interestingly, that atropine is not successful in every case. So atropine is not the first line of treatment. Another patient who denied any symptom of angina or syncope or palpitation, but new onset fatigue. Potassium was only 5.6, creatinine was 2.1, and the home medication, metoprolol and lisinopril. So it got the bradycardia and went into breast syndrome. This is another case that to show you that breast syndrome can lead to brain death. So this patient also, because the physician in the emergency was not aware about the breast syndrome, he started to continue the beta blocker because the patient had coronary artery disease. He didn't look for the history of the patient, and he started to continue the beta blocker. So the patient went into more bradycardia and cardiac arrest in BEA. And after survive, he went into anoxic brain injury. This is another example of patient who was on verapamil. And the patient was on verapamil, calcium channel blocker, and he had pneumonia, which is here the triggering factor, and also potassium was high and the creatinine, and he, of course, treated as verapamil toxicity.
This another patient who were on AF and he was under treatment with digoxin, and he was found to have bradycardia 25, potassium 6.9, and the digoxin level was high, so he was treated by calcium gluconate, fluid, dopamine, and he required digoxin antibody to correct the digoxin toxicity. But he was treated successfully after dialysis. So in conclusion, the diagnosis of BRASH should be clinically, which is two elements, is medication history, which is very important when you see patient with bradycardia or hyperkalemia. You have to dig behind the other element. If bradycardia, look for hyperkalemia. If hyperkalemia, you have to look for using one of these medication. So high index of suspicion should be there in the emergency department. Inappropriate treatment may lead to multi-organ failure, and this because you see the circulatory collapse. Old age and cardiorenal comorbidity are at high risk. Beta blocker is the most implicated medication. The significant mortalities present an opportunity for intervention with timely recognition. You have to treat it early and stop all the medication. Simultaneous early management of bradycardia, hyperkalemia, shock, renal dysfunction early may avoid the escalation to more intensive therapy and worse outcome. So this is the end. It is 4 elements. Each element can start first and push for the second one to be the initiative, and the circle will continue until you stop it by stop this medication and be aware about there is something called BRASH syndrome. And thank you.
Thank you, Professor, as always, for an interesting lecture. Now we would like to invite Dr. Samir Smisim, who will join us online to present his lecture titled Disaster Emergency Medicine, Medical Response. We look forward to hearing his insights on this critical, important topic.
Train our staff how to respond, how to activate, what's useful from our plan. Well, if we will wait until disaster happen, we will wait until disaster happen. Now we will activate, we will fail. We should train, we should do drill, or what we drill every 6 months at least to stay familiar with our plan for disaster. And thank you very much for your distribution. And if there is any question, I am ready. Thank you very much. And I hope I provide what I can help with this topic.
I think the recording did not start from the beginning. Maybe we should start it from the beginning? Thank you.
Scientific and great Congress, the Intercontinental Emergency Congress in Turkey. And secondly, I want to say it's my pleasure to be with you today for our topic, how we respond as medical emergency response for disaster and disaster management. So our objective in the presentation about the topic will be disaster definition, classification, disaster cycle, disaster facing, disaster emergency medical response, how we respond by medically, and incident response system, or ICM. First arrive to the scene, the first ambulance arrived, triage, start triage, disaster transportation, and documentation, and at the end, compensation. Now, see, this is one kind of disaster in the stadium. There is another kind in disaster in the transportation, in the airport, at the mountain, at volcano. So we have a lot or many kinds of disaster. So what's the definition of disaster? What the definition of disaster? As you know, there are a lot of definition of disaster, but the specific one, the most one is disaster is a sudden devastating event causes serious disruption of the function of the community with widespread of material, economic, and environmental losses and damage, which exceed the ability of this community to cope with this problem. Why? Because it does not have all resources to cope with this damage, with these losses. And not all disaster registered and considered as disaster in the United Nations office or as international reduction center for disaster. Why? Because they said it should be at least one of the following criteria should be present to be entered for the disaster, to be entered in the database of the United Nations of Disaster Reduction Center. Which this criteria? What are these criteria? This criteria: first, 10 or more people should be killed, or 100 people should be affected, or a declaration of a state of emergency by the government that there is disaster, and a request. Now, if you have a huge disaster, the statement of the state, the government of the state will declare there is disaster. But the government of the country, maybe the second step, maybe if they can deal nationally with the disaster, it's okay. If no, maybe they ask help from another nations, so they ask international assistance. This the four criteria. One of these criteria should be available or happen. Why? To consider this or to register for the disaster to be registered with it. Next, disaster classification. We talk about definition. Now about disaster classification. As you know, disaster divided to two, depending on the nature of the disaster, what happened. So we have two classified classes of the disaster: human-made disaster, and we have natural disaster. It's from the nature. We cannot do anything. But another one. So if we look here, we have human-made disaster, and this human is divided also or sub-classified to two. What kind? Environmental and technological. How human can make disaster by greenhouse, as with the environment. Greenhouse effect. What? Deforestation, uncontrolled town planning and megacities, drying lakes. This all the effect of a human being on the environment, and this will cause disaster. Also, we have technological. Sometimes people or human being use this chemical materials, nuclear materials, or oil spill. When sometimes ship transport oil in the sea and this destroys the oil and make a disaster in the sea. So we have two types of disaster by human-made, environmental and technological. Also the natural disaster, we have biological as epidemic things, or geophysical as earthquake, volcano, mass of movement, hydrological, floods, mass movement, and meteorological storm, and climatological extreme temperature with hot and even wildfire, the fire of desert. Now, we will talk about also the classification of I will talk about classification of natural disaster, also divided to three. The natural, the most common one, hydrometeorological, This include flood and wave surge, storms, avalanche, droughts, related disaster. So, and we have geophysical disaster. With this include also earthquake. As you know, earthquakes sometimes happen. Every other 2 years happen. Last maybe 2 years ago or 3 years ago, a huge earthquake happens. So, and landslides, volcanic eruption. Now, even times there is some continuous eruption of some volcano. So, biological disaster. You know, biological disaster with exposure to pathogenic micrograms, even these micrograms or organisms by the nature, or even sometimes a human being know it and make disaster. Toxins, bioactive substance, all this will cause disaster. But this natural disaster, we have hydrometeorological, geophysical disaster, biological disaster. So, and this picture, this photo, for this, the most common kind or types of disaster. See this earthquake here, and this floods, and eruption of volcano, and a lot. Here in this slide, what we see, this natural disaster, all kind of natural disaster, all kind of natural disaster. Tornado, drought, earthquake, flood, windstorm, avalanche, volcano, forest fire, tsunami, sandstorm, hurricanes, dust storm, snowstorm, thunderstorm, hailstorm, sinkhole, all this kind of disaster. But before we talk about the most common one. Now we will talk about disaster cycle. What we mean by disaster cycle? We mean by we have four phases for disaster cycle. What this phases? 2 phases before disaster and 2 phases after disaster. So if we will start to see the disaster cycle, we can say the first one, preparation phase, which is, what's the meaning of preparation for disaster? Which is steps we take or taken to reduce expected damage. We expect damage. So what we will do? What kind of damage? What mortality? What will happen? And we will organize to the transportation, the operation, everything we should prepare. And this what happened. We know this next year or after 1 month, 2 months, we have a huge World Cup, football cup. So we need to prepare this stadium, maybe to have 200,000 people. So what we should prepare ourselves. If disaster happens, what we will do, how we will organize, how we will transport, so that's what we mean this operation. For any event, to be good, to be success with this event, you should prepare. Next, damage mitigation phase. This is the second phase, and this also before the disaster. We should conduct before the occurrence of disaster as well preparation that aim to reduce the rate of threats. We should try to do anything to reduce the damage and and reduce the damage and the threats for the people in that. Okay. Next, if the disaster happens. What we will do? We have another 2 phases after disaster. Now disaster happened, we should respond. So the response should be directly after the occurrence. If the disaster declared, so we should respond immediately after the occurrence of the disaster. And this includes rescue work. You know, sometimes you have there is victim at the disaster area with the earthquake, but there are a lot of people lost. So what we should do? We should provide our medical service for these victims as a medical services, but also we should look for rescue for another people who is missed or lost. So we should look for rescue works, looking for survivors, the people who survive, but they still need emergency medical help. So we should treat them, and we should try to, at this response time, we should try to meet the needs of these victims, the basic needs. At least we know why the basic needs, because in the disaster, we don't have all the resources to cover all the people, to treat all the people, to give all the survival. But we should do the basic things. We should do the good thing for the better, for the great number, the good number. We should provide our good service for good number, okay? So I will not give you advanced or more specific or good advanced need only or extra need. No, I give you the basic. I give the basic for the survivor because I have a lot of survival. My resource, not enough. This is a disaster. So recovery phase. After we respond, we should think about recovery now. What will happen? What's the meaning of recovery phase? This recovery phase consists of two phases: reconstruction and rehabilitation. Sometimes in the disaster, if there is earthquake or if there is floods, there is anything, everything will be destroyed or damaged. So what we should try now, as urgent, as a recovery phase, to reconstruct this building, this communication, this station, this hospital. Maybe the hospital destroyed, maybe the clinic, maybe the communication area, the telecoms, all this building destroyed. So what we will do? We should reconstruct them. And rehabilitation for the building or for the people who stay, they can work. So we should do rehabilitation for them. So we finish 4 phases of disaster cycle, extra to the disaster itself. Okay? So now this photo or this image will show us exactly what happened. So, as you see here in the red one, this is a disaster. And mitigation of damage and preparedness, this both phases before disaster. And the green one and the purple one, this is the 3rd and 4th one, this after disaster. So we will start for mitigation and of risk and what will happen. Next, we will prepare ourselves. We should know what the event, if there is any event. We know this every year in this area, maybe this will happen, some floods. So we should prepare ourselves to decrease the damage or the loss. So this in the preparedness and mitigation before disaster happen. Now consider disaster happen, we will respond and we will do recovery phase. Okay? I hope that will be clear for you. And sorry, but it's brief, not as way you want, but because for the time. Facing disaster, how we can face disaster. Planning, first, we have 4 steps we can do. Planning, organization, directing, and controlling. By these ways, we can face disaster. So we will start. Planning. As we said before, the identification, how we plan, I tell you if you are responsible for disaster management, as you are headquarter or you are to work in your responsibility for disaster facing in any company, in any hospital, in any community. So what you think what you should do? First, we'll do planning. So planning about what? When we do planning, we should identify the problem. What we will suspect, what's the problem? Why this happened? How this happened? So the prediction will be by this way. The prediction of future event, preparation. We should suspect what happened and what we know. Organization is necessary. So we should organize effective management of disaster crisis coordination lead to unification of efforts. If we organized our company, our working will be very good. Directing official record, written instruction. We should have written instruction. Disaster happen, this is our plan. Now we will initiate, we will activate our disaster plan, so we will work about it. Controlling the follow-up of direction and to ensure we should follow all the direction, the written direction, that to ensure the effective, the prompt and complete execution of work task. Okay, now we should we would follow our direction to have good result. Now, our topic, we will be as a very quick about About what? About disaster emergency medical response. So what we will do? In emergency medical response, first responder, response, when we respond to disaster, we have first responder, intermediate, paramedic, and nurses. So incident command, we have disaster declared, so we will follow the incident command system. So now we will activate and we follow it. What we mean by incident command system? Provide a standardized approach to managing incident. This standardized approach for managing incident and special event. There is limited use of ICS globally due to the lack of evaluation. As I said, ICS did not have research. It's developed in California in 1970s. The incident command system, we have public information officer, this is the staff of the command, safety, liaison, and we have another section operation, planning chief, logistic, and financial. This incident command, the senior, who is the commander? The incident commander. The incident commander, he is the senior on the scene. It is the command assess need for further resource. This starts with the first when you arrive. The ICS, or incident commander, will give the responsibility. He gives the responsibility to each one at the scene. Inside the command system, scene control, what's the responsibility? He should do scene control, limit access for any civilian, media cameras, maintain out roads and in roads, communication. Now we have incident command for EMS, our work as EMS incident command. We should activate and coordinate with another agency, supervise, triage, tagging, treatment, transportation, difficult medical decision. Okay, who is responsible? He is responsible. The incident command. He is the incident. He will guide and he will be responsible for the difficult. Now, the first ambulance arrived to the scene. What they should do? Senior, most experienced, tax control and request additional support and update safety. So this when the first arrived. Support. See here. No, see all this agency, all kinds of agency arrive and start to work with disaster. So there should be incident command system and commander at the scene, and this will be from the field events. And after that, with each agency should be incident command to arrange. First of arrival, any ambulance arrive at first, they should ask the question, who can help? When they arrive? If I arrive to the scene, I need to know who can help me because I need the resource. So ask the question, who can help? If you can walk, come to this area. So I know these people can work and go to this area. They are green. They can help us. They are at the scene maybe. They are the first responder, military, nursing, whatsoever. You should not consider people will leave their loved people or one. So they should stay with you. So you need to take their help, to take them with you to help you. Okay, now the ambulance arrived. When you arrive, what we should do as was the first ambulance arrived to the scene. They should declare the multiple casualty incident or the disaster. They should declaring, recognize the major incident. They tell the dispatch room what are. Now, and if they need handbands, they will tell the dispatch. Now we'll talk about triage very quickly. A process of sorting injured people into groups. This is what we mean by triage. Triage is used in hospital, emergency room, even in battlefield, even at the scene. Now, with primary, we have two kinds of triage: primary triage and secondary triage. Primary triage, we do it at the scene. Secondary triage, where there is a treatment, we can do another time, triaging for another time. This is the triage. What we mean by start triage review, simple triage and rapid treatment. This is the abbreviation at the meaning of start triage. It will provide us with immediate priority, immediate delayed and walking and decreased. This is a priority for victims at the scene. This is a tax of the triage. It will be as any card. We can put it here or here, but it should be clear and depend on the situation. Or this we can, all of you know, start algorithm. to ask if to check if they can walk will be green, if they cannot breathing, we should open the airway, no breathing immediately, you consider dead, and go for breathing. So we have the conclusion for this triage algorithm, 32 can do, 32 can do. What we mean, if the breathing less than 30 or more than 30. Less than 30, 32 can do, more than 30 it will be critical or critical. If the perfusion more than 2 seconds will be critical. If cannot do, this will be critical. So in the triage area, at the scene, the evacuation area, now with transportation, now we will start to transport. Why? Because we triage all people, green, red, black, and we will, so now the ambulance will arrive. Before transportation, what we should do, patient name, patient admission date, patient definition, what we should know, where the patient will go, to which hospital, who will receive the patient. So this with the ambulance transportation, we have to put the name of the patient name, status, hospital, unit, because we need to do follow-up with them, okay? Now about home messages, what we will, incident command, you should know that incident command system provides a standardized approach to managing incident and special event. If we will let it and we will wait until disaster happen and now come to the response, this will be a disaster, another disaster, okay? Planning for all phases of emergency is essential to overcome medical, non-medical consequences. If we do not plan, we will fail. If we do not have good communication, we should have command system, we should have control, communication, collaboration, and coordination are all necessary component of incident management system. If any disaster happen, if any mass casualty happen, and we don't have this, and the most important, the communication and the incident command system, we will fail for the response. Training, and education are needed to keep the disaster plan current, and to increase knowledge and skills in leadership and decision making. What we mean, this is the last word. Okay, what we mean, if we have our plan, but we do not train our staff how to respond, how to activate, what's the useful from our plan? Well, if we will wait until disaster happen, now we will activate, we will fail. We should train, we should do drill, or what we drill every 6 months at least to stay familiar with our plan for disaster. And thank you very much for your distribution. And if there is any question, I am ready. Thank you very much. And I hope I provide what I can help with this topic.
Thank you so much for this presentation. Thank you all for participating in this insightful session. We explore a wide range of critical emergencies topics, from the clinical prevalence of magnesium levels in ACS through the structure approach in sync and complex interplay in brush syndrome to the strategies in the disaster medicine response. Now it's time for questions. We invite you to ask questions to our speakers. Feel free to share the talks or comments as well.
Dr. Ayman, I don't know whether he's there. Yeah. I was just wondering, should we use metoprolol anymore, especially in elderly patients? Shouldn't we use hydrophilic beta blockers in elderly patients, especially after your presentation?
Is this a question for me?
Me. Yes. Yeah, if I understand your question that about metoprolol in elderly. So far, there is no studies to confirm what I'm going to say, but yes, you are right. Not only metoprolol, we should focus on all the lipophilic
but there is no study to answer your question. Still, metoprolol is one of the best drugs they use from the beta blocker group, and carvedilol also is one of the most common, but there is no study to say which is better for elderly and which is better for the young age.
Why don't we do the study?
We will try if this ethically can be approved, because if we are in doubt about one medicine, it will be face some ethical issue, but if anyone can get the ethical approval for this, it can be a good idea.
This question is for Dr. Sakar. Obviously, hypomagnesium is inversely associated with an elevated CRP, which is obviously a cardiac risk factor. So my question to you is, I know that there is now evidence to treat acute MI with, or the hypomagnesemia in acute MI, but what about discharging all these patients that we have with ACS? Should we be doing a CRP and then sending in a magnesium level and then sending them home with magnesium?
Thank you, sir, for the question. So, we in our institution, we used to not do magnesium for everyone. After this study, we are at least doing magnesium. That's where we stay right now. And probably what you told, maybe we can start trying that. We do CRP in our ED, in our emergency departments. And once the emergency care is taken care, they are under the care of cardiology. So probably we'll have to discuss. Right now, they are not following this. They are not planning discharge with magnesium based on the CRP levels, but I'll just keep that in consideration and discuss. Right now, it's not happening there. Right now, what we do is we measure the levels of magnesium on day 5, and then if the levels are not coming up, probably we'll advise a few more days of hospital stay. And we don't advise discharging with magnesiums. Currently, what we are doing is we advise them, if the levels have not come up on day 5, we are advising them stay for 2 more days. But obviously, we'll have to start thinking about this.
Do we have any other questions? If no, thank you one more time for participating in this session, and now we invite you to the lunch, and the session will be back at 1:30. Thank you.